Right, welcome back to the deep dive. This is where we try to take that absolute fire hose of emergency medicine complexity,
Everything.
everything, the latest sepsis protocols, the most soul-crushing administrative tasks, and we really try to distill it down into something you can actually use on your next shift. And today, we're talking about the thing that stands between you and, finally getting to your car after a brutal shift.
Your charts.
Your documentation. Specifically, how to make sure that all the hours of cognitive labor you just put in don't just, vanish into some administrative abyss.
It's the ultimate ED failure mode, isn't it? I mean, you're standing there about to clock out after a shift at a place like Banner Gateway.
Yeah, where it's just nonstop.
It's nonstop. The acuity is through the roof. And you look at your patient list and you see that classic case, the 7-year-old with some vague atypical chest pain and like 3 comorbidities.
Oh, I know that patient intimately. You order the serial troponins, you get 2 EKGs, a chest x-ray, the full chem panel. You spend a solid 45 minutes, just you, thinking, calculating their pretest probability, deciding if you need a CTPE protocol, managing their pain. You're running them through the entire rule-out ACS pathway.
You did the work, the actual intense, life-saving mental work.
Exactly.
You sweated through the differential, you managed all the immediate risk, and then what happens? 6 hours later, all the labs are negative, the final EKG is stable.
And the patient goes home with a diagnosis of, GERD or costochondritis.
Exactly. And the administrative consequence of all that hard work, you just build a level 4 visit instead of a level 5.
And that is not a rounding error. That's what I think people miss. The difference between a level 4, 99284, and a level 5, 99285, that's where the real money is.
It is.
When I feel like I did a level 5 workup and I bill a level 4, I've basically performed, 46% more work for free?
Yeah.
It's infuriating.
It's literally the financial gap we're talking about. A 99284 has a work RVU of 2.74. The 99285 is a full 4.0. That is a 46% jump in value. It's massive. And capturing that right now is just, it's non-negotiable.
You keep saying right now. Why is this suddenly a fight for survival instead of just, good practice?
Because the financial headwinds are. They're a gale force. We have to think about RVUs, relative value units, as the currency of our work.
Okay.
They account for time, skill, mental effort, the psychological stress, and the work RVUs, the WRVUs, that's the core. That's 50 to 55% of our total compensation calculation. But the CMS conversion factor, that's the dollar amount they pay per RVU. It's shrinking.
Give me the bad news again.
For 2025, the finalized CMS conversion factor is $32.35. That is a 2.83% cut from the year before.
So we're literally being paid less for the same unit of work.
Yes. While our hospitals are dealing with crushing inflation, look at the context. Hospital costs are up, 80% over the last 25 years? Physician payment rates have been basically flat. So if we as clinicians don't maximize our professional billing by accurately documenting our complexity, we are just passively accepting a pay cut every single time we do a complex workup. This isn't just about your paycheck. It's about the financial preservation of the whole ED.
Okay, that definitely lights a fire under the administrative chair. So our mission today is a deep dive exclusively on the post-2023 documentation standard.
Medical decision-making. MDM.
MDM. We're not talking about turning our notes into these unreadable novels.
Yeah.
We're talking about surgically precise documentation of the complex thinking we already do.
Exactly. We are officially in the MDM-only era. The days of note bloat for reimbursement, they are, thankfully, dead.
Okay, so let's level set on the basics, because RVUs can feel like this abstract corporate scorekeeping thing. Why are the EM codes, evaluation and management, why are they our bread and butter?
Because a vast majority, I'm talking 85 to 90% of our emergency medicine reimbursement comes directly from those 5 standard EM codes.
99281 through 99285.
That's it. They're the metric for our standard patient encounters. Most of us, especially in high-volume employed settings, we're compensated, at least in part, by the volume and level of those WRVUs we generate. It's how our employer tracks our productivity.
So if 90% of my income is tied to 5 codes, and the level 5 code, the 99285, is worth almost 50% more than the level 4, I need to know exactly how to reliably capture that level 5. And the biggest, most crucial piece of information for anyone still charting on autopilot is that the old rules, they are completely obsolete.
They're dead, and clinging to them is actively harmful to you. The radical shift that happened in 2023 is that your history, your review of systems, and your physical exam, They are no longer scored for determining the EM level.
Can you say that again for the people in the back who are still clicking 10 body systems in their dot phrase?
History, ROS, and physical exam are not scored. They just need to be medically appropriate for the case. That's it. That's the compliance standard.
I would guess.
Just enough detail to treat the patient. But it is irrelevant to the billing level.
I used to have genuine anxiety trying to document 10 ROS systems for like a simple ankle sprain, just to try and hit that level 5 mark.
We all did.
I'd be clicking off that the patient denies polyuria, denies headache, denies rash, just all this garbage filler text that made the note impossible for the next provider to read.
That was the defining feature of the note bloat era, and it was terrible not just for productivity, but for compliance. That bullet counting habit is now it's irrelevant filler. Worse, if you copy and paste an 18-point ROS for a patient who is altered or intubated and couldn't possibly have given you that history.
Oh, that's a huge red flag.
That's a prime example of documentation cloning risk. It's inaccurate and it raises major audit flags. We have to be surgically precise now.
So we can stop writing the novels, but we have to be laser focused on the one and only thing that determines the EM level in the ED.
Correct. The sole metric for selecting your ED code, 99281 to 99285, is the level of medical decision-making.
Yeah.
MDM. That is it. And to get a specific MDM level, say moderate for a level 4 or high for a level 5, you have to meet the requirements in 2 out of the 3 defined MDM columns.
And just to be super clear, we need to reiterate that time is not a factor here, right? Unlike outpatient billing, time is totally irrelevant for these codes in the ED.
That's right. The time you spend is kind of bundled into the work RVU, but it's not the metric itself. You could see a patient who is clearly septic, spend 15 minutes ordering immediate fluid boluses, broad-spectrum antibiotics, and then hand them off to the ICU team.
Right.
That 15 minutes of intense cognitive work easily justifies a level 5. Because the decision-making was high risk and required extensive data, time only becomes the main factor if you're billing critical care.
99291, 99292.
Exactly, and we'll get to that later.
Okay, let's get to the core of this then. We need to hit high MDM for a level 5 by meeting 2 out of 3 of these MDM columns. Let's break down how to hit that high threshold, that 4.00 WRVU in each column.
Let's do it, starting with column 1, complexity of problems addressed, or COPA.
I think this column is the single most misunderstood one by emergency physicians.
Yeah.
It's not about the final diagnosis, right? It's about the initial threat assessment.
Precisely. We need to just completely eradicate the final diagnosis trap from our thinking.
Okay.
The level of care is determined by your differential diagnosis and the workup you needed to do to rule out the worst-case scenario. High COPA, which is what you need for a level 5, is explicitly defined as addressing one acute or chronic illness or injury that poses a threat to life or bodily function.
That specific language, threat to life or bodily function, that feels like the key phrase we need to embed in our documentation.
It is, absolutely. Just think about the common scenarios we manage every single day at Banner Gateway. An older patient comes in with syncope. The final diagnosis might be vasovagal, sure, but you had to rule out a subarachnoid hemorrhage, a PE, an aortic dissection, a life-threatening arrhythmia. That differential is what justifies the level 5 COPA.
Okay, but how do I phrase that in the note so a coder actually sees it and gets it? If I just list the final benign diagnosis, I'm sunk.
You have to document the problems you addressed. In your assessment, you list the differential. For example, you write, the primary concern driving this workup was rule out acute coronary syndrome and pulmonary embolism, both of which pose a threat to life.
Okay.
Extensive testing was required to reach a secure discharge diagnosis of musculoskeletal pain. That narrative link, it's vital.
So rule out MI, rule out ectopic pregnancy, rule out appendicitis, or, rule out sepsis. These are all inherently level 5 COPA problems, even if the patient goes home with gastritis or a pulled muscle.
They qualify. And don't forget the chronic diseases. If a patient comes in with, well-controlled hypertension, that's not high complexity.
Right.
But if they come in with an acute, severe exacerbation of COPD requiring BiPAP, or new onset acute renal failure from dehydration, that is high complexity, because those problems inherently pose a threat to bodily function.
That's a great actionable tip right there. Use descriptive modifiers. Don't just write COPD. Document severe COPD exacerbation or acute GI bleed. Those words signal high complexity instantly to the coder.
Right. COPA is all about setting the cognitive stage. You have to prove that you were seriously worried about a major life threat. So if we satisfy that column, we need to move to column 2, which requires tangible evidence of the work you did. the data.
And to get to level 5, we need what they call extensive data, which means we have to meet the criteria in 2 out of the 3 data categories under this column 2.
Correct.
Okay, so category 1 seems like the most common and maybe the easiest to satisfy, but it does require you to be diligent about tracking records and tests and historians. Let's start with the documentation review part.
So category 1 covers tests, documents, or independent historians. To hit the moderate data threshold here, which is kind of your first step to getting to extensive, you need a combination of 3 items from this category.
What actually counts as reviewing external records? I mean, my EMR pulls in everything from everywhere. I rarely feel like I'm getting credit for sifting through years of junk notes.
It has to be documentation that originated from outside of your specific ED encounter. And you have to show that you processed it. A general statement like outside records reviewed is useless. You have to specify what you reviewed and how it impacted your decision.
Give me a real-world example from a busy night shift.
Okay, it's 3 a.m. Patient has abdominal pain. They were discharged from another hospital 2 weeks ago with diverticulitis. You need to document something like reviewed prior discharge summary from ValueWise showing complicated diverticulitis. This influenced my decision to order advanced imaging and broad-spectrum antibiotics.
That specificity proves you actually processed it.
It does. Urgent care notes, discharge summaries, nursing home records, even reviewing the state prescription drug monitoring program. All of that counts.
What about the tests we order? Most EMRs auto-populate the lab, so that should be easy credit.
Yes, ordering a test counts, and importantly, a CBC and a BMP, that counts as 2 separate unique tests.
Oh, 2, okay.
Yeah, a troponin and a D-dimer are 2 more unique tests. You accumulate points pretty quickly here.
Okay, here's where the high-level cognitive work really comes in. We need to get credit for the tests we don't order.
This is a huge, often missed opportunity. We are rewarded for considering a test and then deciding not to order it based on established decision rules. You just have to document that process.
Okay, like what?
For example, considered CT head for mild head injury, but patient met all criteria for Canadian head CT rule, so the decision was made to observe only. Or use PRC rule, criteria low, pretest probability for PE, decision made to forego D-dimer.
Documenting that decision-making process is a critical part of hitting that moderate data threshold.
It reflects the true value of an experienced physician, right? Knowing when to stop the testing treadmill.
For sure. Okay, finally, category 1's secret weapon, the independent historian.
A goldmine for almost every pediatric and trauma case. This is history provided by anyone other than the patient who is qualified to give insight. EMS, a spouse, a caregiver, a witness.
So for that 2-year-old with a fever, since I'm relying on the parent to tell me everything, that automatically satisfies the independent historian requirement.
In almost all cases, yes. A parent or guardian of a minor typically counts. For adults, EMS is often the easiest target. They give you critical data like initial scene vitals, or the mechanism of injury that the patient might not remember.
And just to be clear.
Oh, and interpreters do not count.
Right. They're facilitating communication, not providing independent history.
Exactly.
Okay, so if we satisfy category 1, we're at moderate data. Now for the push to extensive data, for level 5, we need to hit category 2 or 3. Let's talk category 2. Independent interpretation of tests.
This is reimbursement gold for emergency medicine because it validates our unique skill set. This credit is given when you interpret a test that is typically interpreted by another specialty.
So radiology or cardiology?
Exactly. EKGs and plain films.
You mentioned a magic phrase earlier. What is it and why is it so important?
It's independently interpreted by myself. The word reviewed is just too vague for coders. It doesn't prove you actually looked at the raw data instead of just glancing at the final report from the specialist. The phrase independently interpreted clearly signals that you, the physician, performed the cognitive work.
So if I interpret an EKG, what's the minimum I have to document?
You have to document at least 3 elements. This is not a formal cardiologist report. It's just proof of your process. You need a dot phrase that pulls up rhythm, rate, axis, QTC, ST changes, etc.
For example?
EKG independently interpreted by myself. Normal sinus rhythm, rate 80. Narrow QRS, no acute ST elevation or depression. Done.
What about plain films? Say, a chest x-ray on that patient with shortness of breath.
You just state your specific finding. CXR, independently interpreted by me, shows no focal consolidation, no pneumothorax. You don't have to wait for the radiologist's final dictation to get credit. You just need to prove you made a clinical judgment based on your own assessment of the image.
And that satisfies category 2, and combined with category 1, You now have extensive data.
You're there.
Wait, a quick challenge point. What if I independently interpret the EKG, but the later cardiology read completely disagrees with my axis or interval assessment?
It doesn't matter for billing the MDM level.
Really?
You are billing for the cognitive work you did at the time of the encounter to drive your management. Your interpretation dictates your treatment plan, right? Ordering more tests, starting a drip. The coder is just looking at your note to see if you perform the service, not to grade your accuracy against the specialist's final report.
Fair enough. Okay, moving to category 3, which is all about communication.
Category 3 is discussion of management with external professionals. This means having a substantive discussion with a consultant, a radiologist, or, most frequently for us in the ED, the hospitalist for an admission.
Oh man, this is the easiest point to miss when you're slammed.
Yeah.
You just hit the admit button in the EMR, dictate patient accepted by Dr. Smith,
Right.
and you forget to document the 20-minute back and forth you had.
And you lose the credit. That conversation, the debate about which antibiotic to use, the admission status, the need for a rapid consult, that is high-level cognitive work.
So what's the tip?
The actionable tip is simple. For every single admission, burn this line into your macro. Discuss management and disposition plan with the hospitalist who will accept the admission. That one line fulfills category 3.
And just to reiterate, talking to the patient's family or sending a quick EMR message that doesn't lead to a real-time discussion, that doesn't count.
Right. It has to be a collaborative discussion about management, synthesizing info, formulating a plan with another professional.
So category 1 plus either category 2 or category 3 gets you to extensive data. Now we've got 2 out of 3 columns. Let's tackle the last one, risk.
This column assesses the risk involved in your specific management decisions, regardless of the final diagnosis. For a level 4 chart, you need moderate risk. For a level 5, you need high risk.
Okay, let's focus on the easiest triggers for level 5 for high risk.
The single most reliable trigger is disposition, the decision regarding hospitalization.
Just the decision.
Just documenting the decision to admit automatically raises the risk column to high. Even if the patient later declines admission and leaves AMA, the fact that you determined it was medically necessary satisfies the high-risk criterion.
What about surgery or procedures?
The decision to send a patient for emergency major surgery like an emergent lap for a perf or an appendectomy, that's high risk. Similarly, performing high-risk, life-saving procedures.
Central lines, intubations.
Exactly. Central line, intubation, chest tube. Those are all high-risk decisions.
And what about the high-risk medications we use every single shift?
The use of parenteral controlled substances is categorized as high risk.
So IV or IM.
Right. If you administer IV or IM, opiates, morphine, fentanyl, hydromorphone, or IV benzos like midazolam for sedation or seizures, that decision automatically satisfies the high-risk threshold.
Okay, this brings us to a really crucial point we need to clarify. There's a separate high-risk category, right?
Yeah.
Drug therapy requiring intensive monitoring for toxicity.
Yes. And the number and hack for getting high risk on an otherwise moderate case.
IV contrast.
IV contrast for a CT scan. The use of IV contrast is explicitly listed by CPT as a high-risk medication, requiring intensive monitoring for potential anaphylaxis, hypersensitivity, or, acute renal toxicity.
That is massive leverage. So if I have a level 4 patient moderate COPA, modern data say belly pain, ruled out surgical cause, but they got a contrasted CT, that use of IV contrast automatically bumps them up to level 5 risk. And that could justify a 99285.
That is precisely correct and totally defensible. That decision requires the cognitive work of checking their renal function, their allergies, monitoring them post-injection. Just documenting CT abdomen pelvis with HOFI contrast ordered is capturing high risk.
And the last high-risk trigger, the really serious conversation about limiting care.
The decision to de-escalate, or complying with an existing DNR or DNI request, that falls into the high-risk category because it involves complex, high-stakes discussion of prognosis and end-of-life care.
Okay, now quickly, what are the most reliable moderate risk actors? The ones crucial for just solidifying a level 4, a 99284 chart.
Prescription drug management is the key one. Ordering any new prescription, deciding to continue complex chronic meds, or giving certain non-critical ED meds like lidocaine for a block, Toradol, Zofran, that all falls here.
So if I send them home with an antibiotic or an oral narcotic, I'm hitting moderate risk.
You're there.
And what about the new addition? Social determinants of health, SDOH. This feels like a lot of work for a level 4 maximum. Is it worth documenting?
It's legitimate, and we should document it when it's applicable. But you're right, it does max out at moderate risk. If the diagnosis or treatment is significantly limited or impacted by SDOH, homelessness, food insecurity, lack of access to care, this supports that moderate risk factor.
So how do we document that efficiently without adding half a page of boilerplate text?
You need two things. First, the right Z code, like Z59.0 for homelessness, attached to the chart. And second, a brief narrative link in your MDM, something like, patient is homeless, disposition complicated due to lack of safe discharge environment, required extended observation.
You link the social factor directly to a change in your management plan.
That's the key.
Okay, so we've mastered the grid. COPA is the threat, data is the evidence and interpretation, and risk is the management decisions. But now we have to apply this to the absolute chaos of the ED floor. The theoretical mastery of the MDM columns just collapses the moment you're trying to manage 3. Level 5 patients, you have sign out in 10 minutes, and the waiting room at Banner Gateway is holding 50 people. The workflow challenge is the reality.
It's the constant pressure of volume over diligence. And the worst habit we all fall into is, I'll fix it later.
Guilty.
Those straggler charts, the ones that get delayed by 30 or 60 days, that's where your RVUs just vanish. Your memory of that complex decision-making process fades. You omit the critical details that justify the level 5, and the coder can't bill what they can't prove.
So the counter strategy has to be real-time documentation, leveraging the EMR's efficiency tools, not fighting against them. We need quick, high-impact documentation hacks.
Absolutely. We need to document the complexity of the decision, not the volume of the text.
Okay, give me the top efficiency hacks for capturing level 5 details right now in the moment.
Number 1, independent interpretation dot phrase. This is it. Burn the phrase independently interpreted by myself into your EMR macros for EKGs and X-rays. Make sure the macro forces you to fill in those 3 required elements. Use it religiously. It costs seconds, but generates massive data credit.
Okay, number 2, how do we quickly link comorbidities to justify that level 5 COPA?
Comorbidity connectivity. Don't just list their past surgical history. In your MDM or your assessment section, dedicate 1 line to complexity. Patient's severe systolic heart failure necessitated higher-level observation. Or, increased threshold for aggressive diuresis due to acute renal injury. You link the chronic disease directly to the work you performed.
This finally validates that mental effort we spend coordinating care for these complex, multi-system failure patients who aren't necessarily intubated.
Exactly. It's the art of good medicine finally aligning with reimbursement. Third, procedure note precision. If you're doing a LAC repair, an IND, a reduction, don't just use a one-liner. Use a quick template that prompts for the details. Size, complexity simple versus intermediate anesthesia type technique. That makes sure you capture the procedure RVU correctly, which is a totally separate billable service.
And the high-yield admission hack for Category 3 data. We need to automate this.
Automate the consultant discussion. Every time you admit a patient, make sure that dot phrase for the hospitalist discussion is triggered. Discuss management with hospitalist Dr. X, who will accept the admission. That is your free Category 3 data point.
What about the new SDOH criteria? Since it's only level 4 risk, should we even bother?
If it truly complicated the care, yes, but keep it tight. The SDOH documentation should just be a 1-line narrative explaining the impact. For example, patient refused medication due to homelessness and inability to store drugs safely, required alternative management plan. You show the complication, you satisfy the requirement, and you move on.
So this all boils down to creating quick templates that force us to capture the MDM elements instead of falling back on those irrelevant history and ROS fields.
Exactly. You need macros labeled LVL5 COPA justification, LVL5 data capture, LVL5 risk factors. They are checklists that remind you, in the middle of the chaos, to capture the work you already did.
All right, now for the fun part. Let's tackle the persistent myths that are still costing us time and money in the ED.
Let's do it. Rapid fire. Bust them.
Okay, myth. If I write a longer review of systems, I get paid more.
Truth. False. Absolutely false. ROS is not scored, it is irrelevant filler, and it risks cloning non-updated, inaccurate information.
Right.
Write a medically appropriate ROS, nothing more. And if you can't get one, document why. History limited due to intoxication due to dementia.
Okay. Myth. Copy-paste macros are a necessity and they save my career.
Truth. They save time, but they are a massive compliance risk if they pull in outdated information.
Like a physical exam from 3 visits ago.
Exactly, or irrelevant systems.
Yeah.
Accuracy beats length, period. You have to make sure that text reflects the current encounter, especially that MDM section.
Myth. The discharge diagnosis decides the level. If the patient goes home, it can't be a level 5.
Truth. False. So false. The differential, the co-PA, and the high-risk decisions, the risk in data, that's what decides the level. A 99285 discharge is perfectly legitimate if the workup was complex and high risk.
That negative chest pain workup.
That negative chest pain workup that required serial troponins, EKG interpretation, and reviewing outside records, that is the perfect level 5 discharge.
Okay, last one. Myth. The facility level and the professional level have to match. So if the hospital bills a level 3 for the room, I can't bill a level 5.
Truth. Absolutely false, and this is a crucial distinction. The facility level is based on resource utilization, CTs, IV fluids, room time, nursing intensity.
Right.
The physician level is based purely on MDM, your cognitive work. You can rule out an aortic dissection with extensive data level 5 MDM, and the patient walks out with pleurisy level 3 facility use. That mismatch is common, it's compliant, and it's defensible because you are billing for different services.
Okay, let's touch on the APPs for a second. The advanced practice providers. If a nurse practitioner or a PA and a physician share a visit, who gets the credit?
That's the split shared rule. And the good news is CMS adopted CPT guidelines, so it's based on MDM, not time. The physician can bill the service if they perform the substantive portion, which is defined as performing or approving the MDM.
So the physician just has to document that they personally made or approved the management plan.
And performed the independent interpretations or discussions, like with the consultants. The physician takes the ultimate responsibility for the complexity that's documented.
Okay, so we've established that for EM codes, time doesn't matter. But we need to briefly but deeply address the one area where time is the only thing that matters.
Critical care.
Critical care.
Yes, codes 99291 and 99292. This is the apex of reimbursement and also the height of audit risk. It's reserved for life-threatening illness or injury, requiring intense physician management to prevent imminent deterioration or death.
Septic shock, massive GI bleed,
Yes.
severe respiratory failure.
All of it. And the crucial rule here, the financial cliff, is the minimum time threshold.
This is a strictly time-based service.
Strictly. You must reach a 30-minute minimum of cumulative critical care time to bill the base code, 99291.
30 minutes.
That code covers 30 to 74 minutes, and it gives you a substantial 4.50 WRVU. If you document 29 minutes, the coder has to revert the encounter back to a standard 99285.
So 30 minutes is the minimum entry fee, and the bonus comes at 75.
Exactly. Hitting 75 minutes of total time lets you bill the add-on code, 99292, which captures an additional 2.25 WRVU. That 75-minute mark is a huge financial milestone, and you have to document every single minute leading up to it.
So we have to be militant about documenting the exact start and end times of what we were doing.
You do. You have to document that time clearly in your note. Total critical care time provided, 62 minutes from 14.15 to 15.1 and then list the activities. Continuous reevaluation, titration of vasopressors, discussion with surgery.
Okay, now for the absolute crucial pitfall that gets every ED physician audited, the subtraction rule.
This is where people lose their critical care time. Time spent on procedures that are separately billable must be subtracted from the total documented critical care time.
Okay, give me the quick list of what needs to be subtracted.
CPR, intubation, central line placement, chest tube insertion, cardioversion.
Emergency ultrasound, if you bill for it.
If it's separately billable, yes. Fracture dislocation reductions, complex wound repairs. These are procedure RVUs that are billed separately. You cannot double dip by including the time you spend doing the procedure in your critical care time.
So if I spend 60 minutes actively managing a hypotensive trauma patient, but 15 of those minutes was physically placing a central line and intubating them, I only bill 45 minutes of critical care time.
That's the correct defensible way to bill it. You bill the procedures separately. The administrative time managing the vent, interpreting the post-intubation x-ray, titrating drips, that's all bundled into the critical care time. The mechanical placement of the line or tube is subtracted.
And the most painful scenario. What if my total time was 40 minutes and I spent 15 minutes of that placing a central line?
You subtract the 15, leaving you with 25 minutes of critical care time.
Right.
And since you failed to meet the 30-minute threshold for a 99291, you can't bill critical care at all. You have to revert the whole encounter back to a high-level EM code, a 99285, plus the separate procedure code for the line.
That 5-minute difference costs the department 4.50 WRVU.
That's why meticulous time tracking is paramount.
Okay, this complexity, especially with APPs and split shared rules, This deserves its own focus session. We will promise a future deep dive just on optimizing critical care documentation.
Yeah, that's a whole can of worms.
It is.
So the central lesson for every clinician working in a high acuity environment like Banner Gateway is clear. The new system rewards your thinking over your typing. Your charts are now administrative artifacts that have to accurately capture the differential, the data you processed, and the level of risk you accepted. You have to stop leaving money on the table for the high-level work you already did.
So to make this immediately applicable, here are the 3 things to document better on your very next shift to capture those level 5 RVUs and make sure your cognitive work is paid for.
All right.
Number 1, use the magic phrase for data capture.
For every EKG or plain film, document independently interpreted by myself, plus at least 3 relevant findings. The single phrase is your ticket to Category 2 data. It's one of the most reliable routes to extensive data every single time.
Number 2, capture the threat, not just the final diagnosis.
Document the high-risk differential in your assessment. Primary concern was rule out ectopic pregnancy torsion, ruled out with ultrasound and HCG. That justifies level 5 COPA, the threat to life, even if the patient goes home with simple menstrual pain.
And number 3, don't forget the high-yield triggers.
Document the decision to hospitalize, that's high risk, or the use of IV contrast for a CT scan. Remember, 5E contrast automatically triggers the high-risk category because it requires intensive monitoring for toxicity. It often elevates an otherwise level 4 chart to a defensible level 5.
This shift is empowering because it scraps all that irrelevant filler text, but it really demands mental discipline and efficient documentation in the moment.
It does. And here's a final provocative thought for you to chew on as you start your next shift.
Okay.
Since physician conversion factors are continuously being reduced and hospital costs are rising exponentially, ensuring you capture your RVUs isn't just about your personal financial health. It's about the financial stability of our entire specialty. The accurate, high-fidelity data you document, that proof of complexity, it's the only defense we have against continuous payer downcoding and the eventual erosion of physician staffing and resources.
So documenting your thinking is professional advocacy.
It is.
Wise words. Master the MDM grid, document your high-risk decisions, and never let that cognitive work disappear into the void. We'll see you next time on The Deep Dive.